I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. Herpes simplex type 1 virus is responsible for approximately 80% of perioral herpes infections. In the immunocompetent, herpes simplex typically causes a group of small vesicles called fever blister to erupt on the upper or lower lip, which heal within days or a couple of weeks. In immunodeficient HIV-infected patients, lesions may extend to neighboring tissues and become chronic, as in this patient who exhibited a cyclovir resistance after many courses of treatment. Note that the nose is also involved. Another example of local extension in an AIDS patient with chronic labial herpes. The story is basically the same for genital lesions mostly caused by herpes virus type 2. A typical example of recurrent herpes virus infection in the immunocompetent person contrasts with a large chronic ulcer in AIDS. Chronic herpes may involve the hair follicles, herpetic folliculitis. Acute gingivitis during primary HSV1 infection. Herpetic stomatitis can be seen in children and young adults without immunosuppression. Chronic HSV producing painful ulcers of the lip punctuate erosions of the palate with secondary infection of the finger. This is called herpetic whitlow. HSV with ulcers on the inside surface of the upper lip and the palate. These lesions are often chronic, become infiltrated, cause a great deal of pain and difficulty in feeding. HSV producing painful fissures on the dorsal surface of the tongue. Note loss of papillae due to committant chronic candidiasis. Primary HSV infection in HIV-infected children can be severe and extend beyond the mouth. HSV can disseminate. Here an example in a child. Individually, these lesions look identical to herpes zoster, but they don't exhibit the typical dermatomal pattern of zoster. Another example of disseminated herpes simplex in an adult. The mainstay of treatment for herpes simplex is a cyclovir or valacyclovir. Foscarnet can be used in case of resistance. Here we see before and after images of treatment with Foscarnet. As is the case with all opportunistic diseases in AIDS, herpes simplex and other infections often occur concomitantly. With oral herpes, candida is particularly frequent. Here the yellow circles show herpes, the white candida. Biopsies show superficial ulceration and dense inflammatory infiltrates. The virus is present in the margins, where it can be revealed and colored with a monoclonal antibody, here specific for HSV1. Touch preparation showing giant cells, characteristic of herpes simplex. Note polynuclear leukocytes for size comparison in this Papa Nicolau coloration. Inclusion bodies are typical of virus-infected cells. Herpes-infected cells stained with a fluorescent monoclonal antibody against HSV. This concludes the presentation on herpes simplex. Let us now turn to herpes zosters or shingles, caused by varicella zoster virus, which is not an AIDS-defining disease, but it is more frequent and more severe in HIV-infected people than in HIV-negative controls. With advancing immunosuppression, complications of zoster increase in frequency. Dissemination, recurrence, post-zoster pain, ocular and neurologic complications, and chronic atypical skin lesions. Herpes zoster starts with a painful rash. The pain may precede the rash by a few days, with a dermatomal distribution. Here is another view of the initial lesion in zoster. Small grouped blisters form and coalesce. Crusts start to form. The lesions may become hemorrhagic. Healing starts with scar formation. These scars may present a problem, particularly on black skin with depigmentation and keloid formation. Zoster may involve any dermatome. Ophthalmic zoster, shown here, is due to involvement of the first branch of the trigeminal nerve. It may cause scarring of the cornea. An example of involvement of the third branch of the trigeminal nerve. Lesions on the outer ear, often associated with facial palsy, point to the facial nerve. This is called the Ramsay-Hunt syndrome. These hypertrophic scars formed after zoster of the segments C5 and C6. Herpes zoster of dermatomes C7 and C8. Particularly in HIV-infected patients, more than one dermatome may be involved. Here is an example of bilateral lesions of a thoracic dermatome. Involvement of L1 and L2, and ever more distant segments L4, L5, S1 and S2. As mentioned, the complications of zoster are more frequent in the HIV-positive population. In very immunodepressed patients, herpes zoster may disseminate. This HIV-infected child had typical zoster involving distal segments of his left leg. However, note the disseminated lesions on his right leg, arms, face and trunk. The close-up shows that these disseminated lesions resemble those of varicella. In patients with advanced immune suppression, varicella zoster virus may cause chronic viremia with variable skin lesions as shown here. A particularly feared complication of chronic zoster infection is PORN, peripheral outer retinal necrosis. Varicella zoster is the most frequent cause in HIV-positive patients. Large areas of the retina are destroyed within a few weeks, leading to blindness. A normal fundus is shown for comparison. Histology of herpes zoster. A blister is shown at low magnification. Higher magnification reveals virus-infected cells with typical nuclear inclusion bodies and giant cells. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.